But yeah, so I mean, today we've got updates with Dr. Delgado, but I think before we really go into the updates, right? Because these are the proposed updates. These are
Right.
not this is not the final rule, correct?
Yes.
So I don't think that most people understand the process. So we could probably spend 2, 3 minutes on the process of how these things come through, right? Like God, Ray, help me out. You were in school more recently than I was.
Oh.
The the really old style cartoon that taught everybody how to write a bill, or not how to write a bill, but how a law is passed, where
Oh
the bill
God,
goes.
that's like elementary school,
Wow.
old
Yeah,
school. What is, it was like Bill,
yeah. So
Bill.
I
It's
mean, yeah,
yeah, yeah.
yeah, yeah, yeah. So but anyways, if anybody remembers that, they're probably
Ah,
laughing pretty hard. But after
that's
everything
classic.
becomes a law, then it goes to the specific department that manages it, and from there they come up with the CFRs. But normally there's a very distinct process, right, Dr. Delgado? So they'll
Yes.
release the proposed rule, their proposed rule January, right around now, late December, early January. They open it up in, I believe, late February, early March, all the way out to beginning of May for public comment and questions.
Right.
So anybody and everybody that cares about the topic puts their 2 cents in. And most of the time, most people that know about it have their hand on the wheel in some way, shape, or form. So you'll have the different lobbying agencies. In healthcare specifically, you always have the American Hospital Association and then the American Medical Association. They both always put their 2 cents in with this stuff. And then usually the specialist organizations that are involved, right? And then come the end of the fiscal year for the federal government, that's when they release the final rule.
That's
That
close to it. The thing with this one in particular is that the OCR, Office of Civil Rights, the OIG, Office of the Inspector General, and a few other organizations have already been talking about this thing for a couple of years. So yes, the process right now is this is what we want to do. But chances are, because this is really all information, is that most of it is going to become a reality. Second part of that is that, like you say, right now it's open for comments. But what we gotta look at is when this some of this thing is gonna pass. And based on me looking at everything, most of it will pass. The problem, and one of the things that they are actually talking about, when I say they, I mean OCR, HSS, all of them is about how much is it gonna cost to implement this. But
that's the painful part.
the other side of the coin is, but if we don't do it, cybercrime has increased so much that now there are corporations that their main service is cybercrime, that they are targeting healthcare because it's so easy and it's costing the United States billions of dollars a year. So the FBI have a unit basically that all they do is cybercrime. So
Yeah, but they
this is
can't do anything because all these organizations and groups are based out of non-extradition countries anyways.
yes,
So they'll even take credit for this crap, wave their hand and say, nanny, nanny, boo boo, you can't get me.
yes. That's what I say. They are organized as a corporation already because nobody can touch them. The funny part about it, the second part that is kind of funny, is that what we have as HIPAA security, the European Union have it also as their requirements for, I would say, electronic transactions. It's very,
Yeah.
very similar to what we had that they already have passing to law. So, yeah, our laws cannot touch them, but maybe those laws can touch them. But the bottom line is, what is here that in my book I say, okay, some of this is makes sense, some of this things are gonna make some changes happen. Some of this is already into law. All they're doing is
Mhm.
tweaking it to make it difficult for people to get away from doing it. So what I want to cover, and again, is so long. When I actually look at the official paper or package, about between 250, 300 pages. And then I already look at
Yay,
some of
light
the,
reading.
yeah, so I'm looking at some of the comments about that because then they say, okay, this is what happening. This is what we propose. This is what the law says. This is how the law is going to change. And then this is how it's going to be implemented.
Hmm.
So it is heavy reading. If you don't understand the laws, you will get lost. But that's why the way I look at it is, okay, so let's look at us. What is our job? And it's more of what have we decided to make our job? Where our job is to look at this thing so that we can implement into EPI the policies and procedures and the tasks that need to be done. The second part of the job is to identify the resources that the officers needed to make it able to implement. The third part of that is look at it, how can they do it in a way that is efficient? Because otherwise they're not going to stay in business. They don't stay in business, it hurts everybody. So how can we help them? And then let me finish one more, because
Okay.
based on some of the things that are saying here, we're going to have to not only change the security risk analysis, but also implement what they call an audit. And let me see, because I brought it over here.
Yeah, it's under your number 7 of the one that you were
Yeah,
talking
it's a
about.
compliance audit. So it's a lot more work that we have to do. It's a lot more information we need to digest and provide. But again, we're not going to go over everything. We
I
will
was
need a week.
I was gonna
No, no,
say,
no.
given the breadth and the depth of these updates, because as you mentioned, there's quite a bit, right?
Yeah.
Well,
We're gonna be hosting
and
several episodes on these. So the goal was to do bite-sized chunks, and
and as more organizations ask questions and make statements, the governing bodies will sometimes release little tidbits to answer the questions so that way they can progress the conversation, right? But I do have one question for you, Dr. Delgado, because this is something that I remember a client of Taino Consultants was asking me about 10 years ago. And I kind of laughed it off as, no, we're not even close to that yet. But I feel like we're getting closer and closer aggressively every year. And at what point are we now at the point where we're not actually spending time treating patients, but we're doing more compliance work than actually healthcare work?
Oh boy.
Because
We're
I'm looking
there.
at it.
No,
I'm
no, no,
looking
no.
at it. You and I have conversations about it with all the ransomwares as the new way that CMS and OIG and OCR and every alphabet agency comes through the office. I'm trying to sit here and I'm trying to say, what where's my loophole? You know what I mean? Like I'm trying to find a loophole and it's getting trickier and trickier.
There's no loophole right now, because this is the other side that I'm working on, which I'm going crazy. Uh, Regardless of the compliance requirement, regardless of the laws that are out there that affect all of us, there's also the component of, let's talk about the insurance. Insurances are the ones practicing medicine, it's not us. So we see that a
Yes.
patient needs a medicine, a
It doesn't
procedure,
matter that, yeah,
a
we got to get the
referral.
prior off.
No. So, but the problem, as a matter of fact, yesterday I was going to write something about that, and I decided to be a little more positive and put it from the standpoint of change. What is change? Because the problem is that people look at health insurance as, if it's not covered by my health insurance, I cannot do it. Well, stop. Let's go back. If it's a medical procedure, medical service that you need, at no point in time did the insurance company say that they were going to cover everything you need or the way you need it. The
Or if you
fact
want
that
it.
they are dictating and creating all of these guidelines doesn't mean that that's what you need is what you need. It's just that, where are you going to pay? Who's going to pay for that? That is really the point. So I have a case in Ocala of a patient that didn't meet Medicare requirements for oxygen to be delivered at her home.
Stop. Stop.
Yeah.
Are you
wow.
serious?
Yes. No. And then the test that Medicare dictated that we needed to do so that we could send the referral for home health to deliver the oxygen, the patient couldn't do. But as primary care, that is where I was working on the environment, we couldn't do anything more. We spent 2-3 weeks trying to figure out a loophole, and we ended up sending it to the pulmonology because he could actually do what needed to be done to the patient, which was basically
Same
send
thing.
oxygen there. Yesterday, I was dealing with another case, something similar, two different cases, but it was the same thing. Insurance or Medicare guidelines will not approve what is required for that patient to have a better quality of life or to treat their illnesses. But patients look at it and say, well, what am I going to do? What am I going to do? I say, pay for it. I'm sorry. If the insurance doesn't pay for the office visit, guess what? You pay for it. But then when you look at the Social Security Act, and this is not really the topic that we were going to talk about, but we call
No. But it
Delgado.
was. I wanted to address the statement because it is a sentiment that I'm getting more and more, and it's one where I don't want to black pill everybody, but I do want to go and say, as someone that's in the mess, as someone that is consulting to clients, we understand, and we have to shift the way we do business.
Yes, yes,
And we have to do something that the insurance companies do not want to do, and that is educate the patients.
right. And that is
Not just about their health, but about their options.
yes, that is exactly what I did with one of the cases. I actually wrote the script for the doctor. I said, listen, the patient is getting mad at the front office, at you, at the referral staff, and there's nothing we can do. So this is the script. I want you to explain to the patient, this is what you need, this is what we're trying to do, and these are the responses. So is passing that responsibility back to the patient. I mean, it sounds simple. It's not, because it's re-educating. And it's easier to educate than to re-educate because they already have this, I would say, this concept of this is what I need. So you have to provide it. And if not, I'm going to sue you. Well, that's where compliance comes in. All of the things that we're looking at compliance, believe it or not, are in a way to protect us. So we have to look at compliance not as, man, I got to do all of these things that the law is telling me to do. It's not about that. It's how do I protect you? So some of the rules that are coming down is because we are so busy trying to treat patients with all the paperwork we have to deal with all the, every time we turn around, somebody's trying to sue us, that you say, stop it. Do you want me? We're here to take care of you. Do you want care or not? And if you don't want the care, then you'll be released. The issue that is going to happen is the following, because there are less and less physician offices accepting insurances.
Yes,
They are
every year that number decreases, and that's including on Medicare. So Medicaid, let's not even talk about it. You're either all in on Medicaid or you're out. Like that's just the way that works. But yeah, I mean, even with the Medicare Advantage plans, it's the same thing it's a different reason, but it's the same result, same net result.
Well, when you really look at it, you're going to see that there's more lawsuits going against the health insurances because they are not following the rules.
Yeah.
Period. They are not paying you even if you send a clean claim. They are not paying you if you send a referral. They don't have in their networks the specialists that they need by law.
Or that they claim.
Or they claim. I mean, when you really look at the insurance directory and you start calling some of those offices, they don't accept that insurance anymore.
No.
But they submit that name, that number as, well, this is what it is. So in reality, we could say, you got my name there. I'm not accepting those patients. I'm going to sue you for that. But return on investment. I'm looking at, okay, so those are the things that are happening. So where is the return on investment? What are the things that me as a doctor looking at my checkbook and I say, I don't have money to cover payroll? What are the things that me as an office manager say, I gotta do too many things. What do? I start at 5 in the morning, 7 o'clock, I'm still there. My life is the practice. I don't have a life. So what do we do? And it all comes down to the basics. It's like you say, Jose, what are we here for? for compliance or to treat patients? What did I go to school for? What fills me with joy? And that's what I say. Listen, this is easy. What do you want to do? And again, there are some services that I tell the doctors, don't even bother. It's not going to pay you. Even though you enjoy doing this thing, it's not going to pay you. The liability is too high. And the patient people that you are looking at are the ones that want to sue you.
No, but I feel like, okay, this is absolutely an opinion, and this is anecdotal at best. But every provider has their pet little thing within the practice that they love to do.
Yeah.
It just so happens that most of the time that one thing doesn't get paid very well. It's the other stuff that they don't like to do that honestly nobody likes to do is where you get paid between the documentation, between the kind of tests that you order, the frequency of it, the order of operations. So when we look at this stuff and we go back to the topic at hand, like how do we shift this into a position to where it is not costing more resources or time when everything about it is wanting you to spend more resources and time?
Okay. There are a couple of things here. Anything that is happening today is the past. Period. So you have to move forward and say, on 3 months, on 6 months, what is the environment going to be like? And then from there, you say, in 3 months, 6 months, where do I want to be? Then once you get those two, you know where you're going. Now, in order to play, what are the rules I have to follow? And then that is harder because there's so many and they're so complex. And depending on the situation is where you say, I'm not going to do it this way because if I do it this way, this is what happened. That's where you have to create that map, that roadmap. That's where we come into play. That's where I say, basically, guys, we are it. Because the thing is, there's a lot of people that call themselves consultants. There's a lot of people that are out there that are service company. And there's a lot of people that know a lot less than us that I couldn't afford. I mean, when you really look at a healthcare attorney, $400, $500 an hour. Wow. If I ask them to write a policy for me, I may be looking at a return of $5,000, and then it may take, depending on what am I doing, a couple more thousands. I don't say don't use healthcare attorneys, just the opposite. Use them for your baseline, but also use other people that really are out there for you, that have the expertise to help you create that roadmap. And then what you can do, okay, helping create the roadmap, I'm going to pass it on to the attorney to review it, approve. Okay, and now I'm going to implement. And that roadmap has to do with what are the services I'm going to be providing? What is the type of patients I want to go after? What is the marketing I'm going to use? And how much I'm going to be charging for that? And then what are my costs of operation that have to account for all of that and allow me to have one thing? An incredible word that sometimes people look at it and in healthcare is not there as often as we used to. Profit. What is the profit? And the profit, and again, because we deal with a lot of owners that are doing a lot of the work, they say, well, I'm making so much profit. I say, no. You got to account for how much will it cost you to hire somebody like you. Then based on that, you calculate the cost, not based on you doing the work. And that will tell you where you are. And then at that point in time, you have to look at what are the changes I need to do to become profitable. But in my life, this is funny. When I was in the Air Force, and I was director of contract and contracting for many years, the first thing I did before I signed a contract was a price analysis. How much does it cost to do this thing for me to know how much are we going to be paying and what is going to be the profit for the contractors or contractor I'm going to hire? In my civilian life with Taino Consultants and EPI and all of the companies we own, in 30 years, have only done one cost analysis, and it was in 1996. And when I did it, I sat down with the doctor that I did it for, and I said, okay, so do you understand what we're talking about? And I say, no, what do you mean? I say, well, what I'm talking to you about is that every minute you spend with a patient talking costs you $5. So if you're
Oh, yeah.
spending, yeah, remember?
Yeah, I've done that. I did that for Panacea Alliance for the practice. I have done that. It hurts your soul a little bit when you do it.
It
It
does.
it it really does because I gotta say that that's when we really started figuring out one, how much it costs, but two, how much you could do it for cheaper if you didn't have to do all the crap for the insurances.
Yeah. And again, the whole industry is changing because number one, there are less doctors. Patients cannot find coverage. So there's more and more people looking to pay for the services because they know. I mean, I have a friend of mine that called me last week and said, listen, my primary care doctor told me he won't be able to see me anymore because they don't accept my insurance anymore. And it's one of the best insurances in the county. Then, shortly after that, she called and said, listen, they changed my cardiology also. And now, and this was 2 weeks ago, I have to
Mhm.
wait until April to be seen.
You're
So
dead.
the
If you
when
gotta wait
you
that long to see a cardiologist,
That's
you're
wild.
dead.
oh
Yeah,
yeah, you're
that's
dead. When I was looking at this, and because this actually started happening about 2 years ago in Miami. And the trend that we saw was that the physicians, the healthcare professionals, let's put it that way, what they were doing was more of the hospitality market because it paid them better than any insurance in Miami. So if you were a patient in Miami, that same doctor had availability for people flying in, but they couldn't see you because your insurance doesn't pay. So why do I do that? So we got to look at it from the standpoint of, like you say, hurts your soul. Yes, we all need money. Money is not a god, but it's a tool that without that tool, we cannot offer services. I go to the point of physician, heal yourself. You got to heal yourself first if you're going to be taking care of somebody else. But if you're taking care of that other person and you're bleeding, guess what? You won't be able to finish the treatment because you cannot afford it. And that's without talking about these changes. Now, guys, in case that you didn't know, rope it back. The idea was to talk a little bit at least about
Well, we
these
were going to split it up
changes.
into two parts, anyways, and we did
Okay.
mention your seventh point over here. So, I mean, we kind of skipped.
we're
We
we're
mentioned a little
skipping
bit
around.
about some of these. Now, I mean, if you'd like, we can really jump into these, but some of these are not going to be as bad if you have a smaller location. If you have multi locations, if you're in that flirting with mid-level, you're screwed. But if you're still like a firmly small practice, the asset inventory and network mapping is not that much different than what already should be being done.
No, it is. Oh my God. It is so bad. It's not funny. And let me tell you they're using the principle of PHI, and for
Mhm,
the inventories, receive, transmit, or storage. Okay.
mhm.
So the network mapping is from the standpoint is created all of the points that EPHI is touching. That's the network. But it
Okay.
also includes your business associate. If you have a billing company, you have an EHR, part of your network is them. And you have to
Yeah.
include their resources as part of your mapping and the equipment that you're using, even though they're business associates.
There's no way they're going to be able to
That's
enforce
crazy.
that.
Wait, like I say, there's more. Well, there's more
Because
because,
because hypothetically, right? Like your patient, I'm doctor.
yes,
We use a video conferencing tool.
yes,
We use an EHR.
yes,
Let's add the billing company in there,
yes,
right? the billing company, are you also having to include the process or the exchange and then the insurance company,
No,
of which we have no control over the
no.
EHR,
They,
the
right.
exchange, the insurance company, like the
Yes,
billing company, you don't have control over your business associate.
yeah,
There's
but
no
that's the
teeth on
problem.
that.
There is right now, there in the guidance, and again, they have been talking about this for a long time. Business
Yeah.
associate. How many people have been able to get a business associate agreement from a business associate? I mean, especially something as simple as an IT company. Well,
You're,
right now, one of the things
Yeah.
that they're saying is if they don't comply, you terminate their contract. They also say here now that they have to submit the business associate a report saying that they are in compliance with all of these things, included on the network. So they are you doing a lot of things just targeting the business associate because they know that's a weakness. I mean, and the
But
funny part is this. Wait, because I know you want to jump, but this is the key part here, is that in reality, when you look at it, there are people that are not business associates that are just suppliers that indirectly they have PHI that you submitted and they have a breach. They never tell you. And that's why the last settlement that I read about 2 weeks ago was $200,000 because there was a breach that was not reported. So it became to $200,000. So but why did the breach happen? I mean, there's so many.
are you referring to like a medical
well,
carrier situation or
Uh, well, that I will explain about that more later. But
yeah.
like in the case of a supplier, diabetic supplier,
Mhm.
okay.
well, all they're doing is receiving an order that even the patient is saying, "Send me this thing."
Okay.
Well, if they have a breach, they have the name of the patients. They have all the information. Is it PHI? Well,
Yeah, it's on them.
yeah, but
It's because they're their own supplier. They're a DME company. They got to follow all those same rules. They're a covered entity.
not
They're a
necessarily.
referral. It's a
Not,
referral.
no. That's not what it makes. Then I can refer patients to you. I can send orders to you. That does not make you a business associate. Electronic
Agreed.
transactions make you a business associate. So if the patient is paying cash,
All right.
the information I'm sending you may
All
not be
right.
considered to be a business associate.
Okay. All right.
If you
All right. I'm
bill
following you. If it, all
electronically,
right. All right.
now it is a business associate.
Okay.
So we could have a supplier case, which actually we have, that
Mhm.
there was a breach of all the patient information, but then they found a loophole to nail them, and the cover entity that was not a cover entity at that point in time because they didn't have a business associate relationship. And they nailed them.
Let me ask then. All right. Based on that logic, you ready for this one?
No, I don't want to hear it.
Anytime, anytime. No, 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 no. Based on that logic, you literally is it even worth working with a hospital if you're a small practice? Because if the breach happens on their end, they're going to skewer you. If it happens on
Oh,
your end, you're skewered.
oh yes.
So
Is it
lose
even worth
lose.
working with a hospital? I'm screwed no matter what then in that
Well,
scenario because it's the same methodology.
but it all depends what are you doing with the hospital. You see, it all depends
Receiving
on
a
the
patient.
situation.
I'm getting an order out of an ER. I'm sending a patient for a lab or an imaging, or I'm sending a patient for a surgery. Like it doesn't matter. It all flows back and forth, and we're screwed no matter how you put it then.
Well, in a
Because
way,
what
it's based on
that
interpretation.
logic is super soft with the
No, no, no,
DME.
no. I'm going to actually add more to that, which is actually the opposite of what everybody will think. Let's say that you're dealing with a hospital. There's a
Yeah,
brief. If the
yeah,
patient is yours, the PHI was maybe even in the transition
yeah, yeah.
transaction, because the hospital is designated as an entity that have more resources because they are bigger. The fines and the resolution and all the actions will be greater than if it was you as a small office. But it gets better the chances of something happening are greater because the
because the
hospital
hospital.
have more equipment and more connection, more transactions. So from the standpoint of liability, is and again interpretation.
Mhm.
It will be better to work with a smaller lab, surgical center than with a hospital because
It's going to
then
be
at the
cheaper
same
for the
time,
patient anyways. They'll probably be able to get in faster and get better care. But okay, but my problem is that again, if you use that logic across the board, the entire purpose behind an ACO or an MSO is bunk because the liability is too great. It makes me wonder about having 1099 providers.
oh yes,
Mhm.
yes, that's a
Because
big
if
Point.
you can't get
liability.
an IT company to do this, you think you're going to get a 1099 provider to do it?
Well, think
If
about
you
ER
can do
doctor.
that, if somebody can do that on a regular basis, I want to take classes with them. I want to
Okay,
intern with them. I'll do it for free.
It's
yeah,
too much
okay.
work for a 1099, I feel like.
No, this
It's
is the problem. When you really look at certain departments of the hospital, for example,
radiology.
imaging, radiology, ER, anesthesiologists, a lot of those doctors
If you're a
are
rural hospital,
1099.
everything's telemedicine in.
Yep. And there have been dental offices that the way I set them up is that every dentist, we didn't hire the dentist, we hired the corporation of the dentist. So that then each dentist is a 1099.
Mhm.
So by default, and again, this is interpretation. There are different rules, so I'm just doing big broad strokes. Each one of those should have their own compliance program.
There's got to be and I hate to put it like this, but there's got to be a shortcut that can make this make sense. Because between that and between some of the other rules, it's almost killing the 1099 market.
Well, then let's look at really, like I say, there's going to be a lot of interpretations. And the law, people think that the law is something that is rigid. But in reality, when you look at the law, is what was the intent, and can you
Hmm.
prove that you were trying to follow the intent of the law?
Hmm.
So there are cases, and I can only refer to one, and I will not say anything about it,
Yeah.
where by all intents they broke the law. They were going to be removed from any
Yeah. 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 Yeah.
program license and all that. But I was able to prove that there was no intent to break the law. So if you can prove the intent, it's fine. So when we're looking at all of these rules, what we gotta look at is number one, no longer can you just simply say, I had policies and procedures. No, that is not going to hack it anymore. You need to make sure that you are at least are familiar with what's in the content of those policies and procedures. But it's because what is the point of having a paper bag full of
Hmm.
pages?
Hmm.
It's nothing. The idea of policies and procedures, and I go back to my military days. When I used to fly, I have the checklist of the plane
Hmm.
in a binder strapped to my leg.
Hmm.
You better believe it that I knew even where the dots were by heart. I still had that. What did I do with that?
Understood.
I referred to it to make sure that everything we did was efficient, was safe, and I could get home the next day or that night. So,
However, however, your policies would not be larger than the King James Bible right now.
well, in that case, yes. But
That's
trust me,
true.
I had a bind that it
I
was
mean,
bigger than that. It's just
I
that
could
those
probably
were
make
the
a
emergency
suit with
policies.
how many
I can
pieces of
imagine the
paper
policies
I
on flying a
need,
plane could be pretty
like
pretty
just
large.
for HIPAA security. Forget all the other ones. So,
Okay,
okay,
but
all
this
right,
but
let me ask a question.
go.
If the federal government is going to force us, because nothing is done with a carrot, it's always done with a stick, especially for the healthcare industry, because we ignore the carrots anyways, because it's compliance. Um, what teeth are they going to give the covered entity other than I can cancel a contract because we've been able to do that since Obama
Right.
to force these business associates to not only say that they're doing it, to not only sign the business associate, but then provide proof. Like,
In
what teeth
reality,
is there? Because they're not billing, they're not receiving federal funding, they're receiving funding from us. We have no teeth in this.
no, you're right. The covered entity has no teeth to enforce to the business associates other than terminating the relationship. That's it.
So then they can literally lie to us and we're still going to get in trouble for this. So then is the best thing for us to do just have an email chain where they're admitting that they're saying that they're doing things and then that's it?
No, you cannot. Because if you
There's
do
gotta
that,
be.
uh, I mean, again, they can commit fraud and
Huh?
say, yes, I'm doing all of this thing here, make papers, and that's it. The federal government is not asking you at this point in time, although when I'm looking at that,
You and I both know where this is going to go.
oh yeah, but when I'm looking at the compliance audit, it is looking fishy in terms of that. But this is where I want to go. Is in a way, what we need to do is look at it not as a no. When they tell you, and like in your case, Jose, eat your vegetables.
Mhm.
No. I'm not gonna eat my vegetables. Well,
Mhm.
the federal government is actually trying to say that in order for you and your business to be safe, these are the things that you have to do. And look at it from the standpoint, because I'm pretty much in terms with this thing.
Yeah.
When I start a business, okay, this is what the front office needs to do. So those are my policies and procedures. And in some cases, and this is the script. And these are the
Mhm.
forms that you're going to use when a patient comes in for me to make sure that I get paid. So all they are doing is doing that with security in this case, is what we're talking about. So they're saying, yes, do have policies and procedures, but make sure that your people understand it. Make sure that your people can have access to them, because everybody know
Mhm.
about password, but tell them, okay, but what are the requirements about password? Okay, what do you do when this thing happen? They don't know and they don't care and they don't look at it. So they're saying, well, stop. What's the point of you going through all this trouble or having all those policies of you as a business owner implementing some procedures that they're not going to happen? I mean, if I implement a procedure for somebody in my office and tell them, this is what you have to do, you don't do it, you get fired. Why? Because number one, with OSHA, I have one person, really good clerk, front office clerk. She was amazing. I told her, listen, one time I found her in one of the chairs with wheels underneath, climbing to reach out to something. And I told her, please don't do that. It's an OSHA violation. You can fall.
Yeah.
Fine. Later, I found her doing it again. Listen, I'm not joking. I need to make sure that you have a safe workplace, work environment. You're not following the rules, you're going to get hurt. Third time she was gone. I had to fire her. If you're not paying attention to the things that I'm telling you that can hurt you, and you keep
Mhm.
doing it, I mean, I brought a step ladder, but she was still climbing on the chair. So somebody like that, you're not following the policies. The policies are not there to create more work. They're there because, listen, you should be doing this and you're not doing it. So let me help you by telling you, you got to do this, and that. The issue here is that healthcare technology, or actually technology, all of us, technology is increasing exponentially. We are using technology for everything. The way I look at HIPAA security is I'm looking at it to implement in my own home, in my personal site. Why? Because I know that it's easier and less risk for somebody to basically hack my phone, get into my computer, get my money that is in the bank, my account. I mean, for all God's sake, they're even buying you and selling your house electronically, and you don't even realize. It's cheaper and less risk to do that than trying to get into your house to steal there, than trying to get you outside to steal. So
Stood.
if we are getting a cybercrime to the point that it's affecting me so much, and I even have to look at that from the standpoint of personal. Why shouldn't I look at that and change it to protect my business?
Understood. Understood. And I'm not saying that I'm trying to play an adversarial role with you just so that way we can get a real solution, right? Because I look at this as a policy prescription, and more than likely, you and I both know most of this is not going to change by September when they put the final rule out. So I'm just trying to figure out how, one, we can get ahead, but two, how we can influence someone from another corporation to prove that they're following the rules that you and I both know are so onerous, they don't have the resources to do it.
Okay. And the
Does that make any sense?
yes, it does, and I do have the answer for you on that. How do you eat an elephant?
Agreed.
One bite at a
But this
time.
isn't asking for that. This isn't asking for how do you eat an elephant. This is
Yeah.
all right, we're doing this in one meal. Everybody sit down. You know,
No, no,
every
no, no,
pizza is a
no.
personal pizza if you try hard enough. You know what I mean? Like this
It,
is where we're going.
it,
Let's
it,
go. Saddle
no.
up.
It's like
It's
so far.
too much for one
It's
sitting.
yeah.
Right?
This is one of the things that I look at in terms of, and I go back to the inventory.
Yeah.
With all of the SRS we are doing, we
Yeah.
really had never received a complete inventory because
No.
people were thinking about workstations based on computers. Now,
Yeah.
part of the definition, and that's why they changed of what is a workstation. Well, now they are coming very clear to say, and I got it over here because I said, Dan, is
Yeah.
a workstation, okay, a server, a virtual device, a mobile device such as a smartphone or tablet, and
Yeah.
that includes medical devices,
Yeah.
virtual server, or virtual desktop computer, which is
Okay.
what we know. Now, thermometers may be intelligent enough to keep all your information. I mean, when I was looking at fax copiers, that
Yeah.
people were saying, well, that's not a workstation. It doesn't have any PHI. Well, every time you copy something, there is a
Uh,
memory. It's in the drum.
We
So,
could we talked
Let
about
me
that,
ask you a
Jose.
stupid question.
yes,
This would include the virtual monitoring that a lot of these MSOs and Medicare Advantage companies are doing, wouldn't it?
yes, yes.
How
What
are
is
you
it? You
gonna?
said virtual
How
monitor?
would you even attempt to? You couldn't drop ship it anymore. It'd have to go to a warehouse to IT so you could get the information you need to put it on this mapping.
Yes.
Virtual monitoring,
Yes.
Jose?
Yeah, so you can't. So a lot of concierge companies do it. Some
Uh,
Medicare Advantage companies do it. Some of the self-insured companies do it, where they'll get everybody a smartwatch to
huh.
track everybody's steps and heart rate and weight and all that stuff. And in lieu, you do the extra monitoring so you can get a discount on your rates.
Like,
Blue Cross was doing it in Florida for the last 10 years.
yes.
I think they stopped doing it because so many people were doing it. But
Some auto insurance companies do that stuff too.
well,
Right.
let's not even talk about auto insurance right now.
Same
Those guys
concept,
are
same
something else.
concept though.
Yeah, same concept though, right?
Yeah.
So, but the
Yes.
problem is that if I do that, I can't drop ship it from the manufacturer anymore.
Well,
Because I'm having a hard enough time getting the patient to use the device as intended. Now you want me to get all the information I need to. No. Okay. All
okay.
right.
So
So,
look at this in this way, Jose. Because again,
Yeah.
I'm not saying that it's perfect. I'm not saying that all the answers, the logistics, the implementation is out there. But I will say now, about 20 years ago, when we created our first EHR, okay?
Yeah. I remember those days.
Yeah, well, then at that point in time, one of the things that we were actually concerned was not that somebody would have the ability to actually penetrate the EHR based on the security we had, but somebody may have the ability to actually get into your computer and see the screen that you have. So
Agreed.
how do we protect about that? In our case, it was every time that you hit a key, it changed encryption. So it basically boot somebody out so you could work, and it was changing the encryption every single time. But
Okay.
right now, what you're saying about these devices, when you look at their encryption and the firewalls,
They don't have
they
any.
no, they have some, but it's so weak, it's a joke. I could tell you right now, and this is the sad part about cybercrime. I bet you just about anything that the three of us, our whole information, date of birth, social
Oh
security number,
yeah.
address, all that has been compromised and can be found on the black web. It all
Thanks,
depends on
change.
how much. Most of the people, they don't realize it. I mean, just now they're coming with something that we talked about before, Alexa,
Yeah.
Oh
recording
yeah.
the time and sending that information. I mean,
Siri too.
yes.
Siri.
So the thing is, okay, so where do I start? So look at these, I would say,
Okay.
compliance requirements as a map to help us start. They cannot do it to you personally, so they do it on the business, on healthcare. But I would
Okay.
basically say to all of you, look at it from the standpoint of how much of this can you implement in your day to day? And that's kind of what the government is saying. What do you need to do to implement on day to day? The risk analysis. I was scratching my head because I said, holy cow, their definition, the way they're putting the risk analysis, is actually talking more of a security management plan, looking at all potential hazards that can affect the office. And that includes both natural hazards as well as cybercrime. So in the security risk analysis, we may need to address fires, like in LA.
Mm.
We may need to address hurricane, floods, all of that. And then we also need to go into cybersecurity. But then the ability or the compliance factor of that particular entity will actually cover in what they're calling the compliance audit. And now they're saying this is mandatory every year. Both the compliance audits, the networking, the update the networking, and the security risk analysis. But we still have clients that either they do it or they have a 2, 3 pages saying, oh, this is my security risk analysis, where I say, throw it, burn it out, because now you have more liability than if you would have done it, because it shows you know what needed to be done and what you did doesn't meet the requirement. I mean, no offense to some of the security managers or even the IT companies, but the security risk analysis covers legal, administration, physical, technology. It's very difficult to accomplish that. Even for us, the bar is higher. So I'm going to be changing our protocols. I'm going to be changing our security risk analysis. I'm going to look for more resources so we can take care of our clients. That's what
Agreed.
it is.
Agreed. How are they proposing that this asset piece is supposed to prevent business associates from getting hacked and ransomware? Now
Well,
that everybody's determined that the business associates, and Ray and I have looked at it on the naughty list,
mhm.
that I would venture to say 35 to 40% of the major hacks are business associate related.
Yes.
How is that going to prevent that? Because it wouldn't. If I look at the ransomware case from Ascension,
Mhm.
this mapping would not have prevented it. If I look at the change healthcare piece, it wouldn't have prevented it.
Yeah, but you're missing one little point because the mapping and the networking also have
The
to say,
mapping and networking isn't going to stop these situations. It maybe can diagnose a weak spot, but it's not going to solve the problem.
okay,
Maybe.
I will actually dare to bet $1,000 for you because I know you
Okay.
cannot afford more than that. Okay.
Ha! I have two kids under the age of 8. Yeah, you're
Yeah.
right.
I feel
In
you.
Yeah. So the bet is how many clients we have that have a complete inventory in terms of equipment based on the way they say it here. And my point is not
They
that
didn't have it on, most of them didn't have it on the last one. You think they're going to have it on this one? You're
I
wild.
know, I know, but my point is,
EPICompliance users are 100%.
When they fill it out.
yeah,
Right?
they're 100% on having the
Of
policy.
having
Yeah.
it. Yep. Yep.
Yeah, but this is basically what happens. How can you protect a resource that you have not identified it exists? It's impossible.
Agreed.
True.
It's a
Agreed. But
blind
based,
side that is going to get you. And we see that happening all the time. The second part, again, everything that you mentioned is more of human error. They, and I wish I
well,
had enough time.
so the Ascension one was 100% human error,
Human
but
error.
the
Yes.
Yeah.
change one would never have been caught up on the mapping because most people would have stopped at the EHR level, not gone to the exchange level. And there's no way if I can't make a business associate do what they need to do, there's no way I'm going to be able to make a business associate of a business associate do
Okay.
it.
Okay. I know. But this is what we got to look at. Okay. Number one, I go back to what are the challenges that we're facing?
Agreed.
Number two,
I'm using this as a brainstorming. I don't know if anybody's
I, I,
noticed this. I'm
I
not
know.
trying to blackmail anybody. I'm just brainstorming with everybody.
Okay. So number one is what are the challenges?
Yeah.
Number two, what are the variables that are
Yeah.
there? And number three, what are the things that we can do moving forward? Okay. So right now we're looking at the challenges of this proposal. Number two,
Yeah.
we have talked about the variables, the business associate, the servers, the virtual, and that's what we know now. Know what's coming down the pipe in terms of technology and software in the next couple of years. Number three, what can we do? Well, this is simple. This is on us first to
Agreed.
identify the information and basically provide it in bite-sized levels to our
Yep.
customers so they can understand this is what's happening and this is what you need to do. Number two, to create the tools so that they can implement in the workplace. But I don't want somebody that doesn't understand the tool implementing the tool. So that's where comes the training. We need to
The
train them. These are the
complexity.
requirements. This is why, because a lot of the time, owners and one, we don't want to spend more money than what we have to. But right now, you will have to. And then the
The
number four,
complexity of
okay,
this.
is
I'm just looking at this.
yeah,
This is
well,
just this is awful.
well,
Like,
look at it.
even if we had a tool where it was literally like, here's a bubble, and this bubble connects to that bubble, and that bubble has breaks it down to more bubbles. Like I'm breaking this down like I had to write an essay back in middle school, right?
Yes.
Like my main theme, my main source, my points of the main point, right?
Okay, so this is what I see. We as Taino consultants, we're going to have to, or actually, we have always been able to do it, but transmit that to the clients. Let's look at your business. Let's make sure that your business is organized in a way that will be successful, that there will be
Mhm.
the element of profit in there while you are implementing the compliance the right way. Then, from the standpoint of EPI, it is for us to create the policies, the
Hmm.
tasks, the training for them to be able to follow that without having to spend, which basically it look in some cases, paying somebody or becoming employees of somebody because you're going to pay this company so much that the business is not yours. It's
Yeah.
theirs. You haven't realized it. So
Yeah.
that's what AP compliance should be about. Policies, tasks, training to help them out implement in a way that is cost effective. Taino,
Agreed.
we're going to make sure that they are actually doing it the right way so that they can keep the element of their business running and having the independence that they will want to have. But I will tell you right now, there's going to be less smaller business because a lot of the doctors are saying, I'm done. I'm done with all of this paperwork. I'm done with all of this compliance. And that is going to affect us as a whole because I'm looking at it and I say, well, which doctor is going to see me in the next couple of years? Which doctor is going to see my kids, my grandkids? So, how do we keep healthcare healthy? And I don't think that anybody's, well, a lot of people are looking at it, but it's not an easy answer. And you just have to start one step at a time. Insurance says, oh boy, that's going to be a bigger problem because of the way they are doing it. But that has been
Never
identified.
follow this. There's no way they will follow this.
They
It will
will.
never. You know what? I'll propose $1,000. There's not one insurance company that's going to get this done before January of next year.
There's no one that is going to do the whole thing. They're going to be
They're not
different.
going to do it.
No, they're going to have mirrors showing that, oh, yeah, we're doing it. But when you go past that, they're not doing
Not
it.
doing it.
Hospitals are not going to have the funds to do it either.
How? They just got a
Organization,
3% raise. Um,
yeah,
they
but
took it out of outpatient.
yes,
But
but it,
if I'm a hospital, it's just better for me to just jump into a system,
yes,
merge with a system that already has all the specialists, all the billing, all the nonsense in-house, and call it a freaking day.
yeah. But what
Share the load all over. That's
that's
the
not what is happening. What's happening is that, and again, we're getting to the point of the
yeah, 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 yeah.
goal time. But what is happening is that some hospitals are selling to venture capitalists. Venture
Yeah,
capitalists basically buy the building, buy the assets.
yeah,
Now the
yeah.
hospital have to pay the venture capitalists, so they're making money based on the rent,
Twice.
based on the access, based on the
They're
lease
making money
twice.
twice.
And then the
Controlling
hospital
the lives and then controlling the land.
Right. And then the hospital goes bankrupt, but they don't care because they still have the physical asset that they can sell that they have been making money on those all the time.
Which is like Stewart Healthcare in
That's
Massachusetts that
terrible.
just had to close like 3 hospitals last year because they
Yeah.
went bankrupt.
In Puerto Rico is the same. I mean, I actually had the Secretary of Health a couple of years back, I mean, a couple of decades back, reaching out to me to sell me some hospitals. And it was just a business transaction. So we got to look at little further than just the business. We got to look at what are we willing to do? What can we do? And then each person has to be jump on board and say, okay, what are the risks I'm willing to live with? And not so much about compliance. It's about business. Okay, what are the things I want my staff to know? I need to provide my staff the resources, the tools to be able to do the job so I can take care of the patients. I need to train the
Agreed.
patients so that they know what they're facing so that I will not, never, ever compromise the life of a patient. Period. The only difference for us is that in this environment, our patients are our clients and
Mhm.
I'm not willing to compromise their health and safety for money. So how do we do it? And that's what we need to do. But with that, it is too sorry, gentlemen.
Yeah.
Most
When
people
we develop the
participate.
tool,
Yeah,
Ray, we're
that's
probably gonna have to do a video on just how to use this bloody thing.
Well, just
Because
explain first.
there's no way we're gonna be able to get this down to the point to where someone who barely knows how to fill out the last form is gonna be able to do
well, what
this.
we discussed mostly today, point 7, point 8, and a little bit of point
Point
4
three.
or point 3.
3.
Yeah, we can split this into another one. It'll probably be
No, 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 no.
closer.
But once we develop the tool for EPI compliance,
Sure.
we're gonna have to do something about like a training video because if
Oh, of
not,
course.
the amount of questions that you're gonna have, Ray, is just wild.
I'm already developing the tool. I already have the some of the tasking. I'm already ahead on that, guys.
We'll
All
be
I need to
ready.
do is change the some of the what to and information. But I'm already
No,
working on it.
agreed.
So,
I'm just going ahead and
Ray, if
yeah.
anybody
Jose, don't
wants
worry about
to,
me. We'll manage.
Oh, I
okay,
know we will. I know we
Because I
will.
mean, the good thing is at the end of the day, that's part of what we do here at Epi Compliance. Our goal is to stay ahead of the game, right?
yes,
And provide.
okay. I'm leaving, but Ray, share with the participants that I do have the blog on Taino talking about some of this.
Yeah, I did share it earlier in
Okay,
today's session,
okay.
and
You
then
can also share the extended documentation I sent you today, the four
okay,
pages. It's not
perfect.
only for a few topics, but that will help. Okay.
Yeah.
And with that, I do have to say bye. Any questions, send it
Nope.
to me. I gotta go to my next meeting. Okay.
Perfect.
No
Have a great
worries,
day.
We'll
Dr.
talk in a little
Delgado.
bit.
Appreciate your
Okay.
time as always. We'll see
Okay.
you. We'll see you on the next one.
Okay. Bye.
So for those that are still on here, if you guys have any questions or concerns, please feel free to share that in chat. And as Dr. Delgado mentioned, he did provide Jose and myself a small article outside the link that I posted here in the chat. We'll get that sent over to you guys post webinar, so you guys have that in hand. But if you guys have any questions, concerns, please feel free to throw your any questions in chat. Hope you guys found this webinar beneficial. I mean, the main thing that I
Tracy, I
got out
hope
of
you
this, Jose,
enjoyed this.
yeah,
This is literally how I process things. The oh crap moments and then the okay, we handle it like this, and this. With
I went.
Dr. Delgado here, you really see how the sounding boards work, usually
Mm,
daily, if not every other day. Um, yeah, especially with all the fun emails Ray sends us with, hey, so we have a client that has this, and then we're like, oh boy, all right, let's sit
it's good
down.
for me because I always, you know what? Let's make it a webinar topic while we're at it.
No. It is good. It is good. It's just a matter of how
We're
do you
walking through it.
process it, right?
Yep.
Because we have to process the problem so that way we can get to the solution. But then we have one more piece, which is translating the solution into something that anybody can actually understand,
Right. Right.
which is it's and this is not to say that anybody is dumb by any means. It's just that these rules are sometimes written so stupidly
It is.
that we just we
I
have
will
to
say
like
one thing I got from
decipher
this
what it
is,
means. Huh?
I said one thing I did get from this is, yeah, there's a lot of changes proposed in this. But
And this is
these
just
things
the first
actually
part.
will these things actually come to fruition? You said September is usually when they release the.
August, September. So keep an eye on the end of the fiscal year for the federal government. And
Mhm.
that's usually when the final rule comes out. So you like right now, end of January till about the end of March, you'll have the open period, and then from March they take the summer to write up the final rule. They say they take into account a lot of comments, but I haven't noticed that anything has shifted too much one way or another when they release the proposed rule.
Sure.
There may be like a sentence here, a sentence there, but nothing too crazy in my experience anyways. So, but
Well,
yeah,
we'll
so next
see,
week
but
we've got another interview, correct?
yeah, so next week we're going to be interviewing with Rick Garcia with Aroa Biosurgery, a territory manager here in the Northeast Florida. He's got over a decade of experience in the public and private health sectors, and this topic is, and just a quick bio on Aroa Biosurgery, they do wound care, or they
Okay.
create wound care products for clinicians and improve, and obviously their goal is to improve patient outcomes. So I think we're going to interview him a little bit on that technology that he provides and to these providers, and a little bit of maybe if there's any compliance in that industry. So,
I would love to know what level of provider you would need to be able to do some of this stuff.
well, I can tell you this much: when I met Rick, funny story, he obviously he went to our Epi conferences event. He took the wound care certification course. That is it was it Dr. Yesenia that was providing?
Yep. Yep.
And that's when I met him. And then he's located here in Northeast Florida. He's in our backyard. He met with a primary care doctor, and he asked if I could come along because they were interested in compliance. And so I got to hear his presentation towards the it was primary care doctor that I guess in his situation, if he's ever dealing with any burn
Okay.
patients, sort of minor injuries towards that. But this product, it can treat up to, uh, what do you call it? Somebody that's bedridden,
Gout.
maybe has some crazy ulcers or things like that
Yeah.
going on. So the product itself is very interesting. Sounds like he deals with a lot of different providers, but like I said, we were just, that particular time when I met with him, we were just speaking with just a primary care physician that, occasionally
Oh,
deals with a burn victim or, whatnot. So, but
sounds good.
looking forward to that. And then,
So don't eat lunch right before people in case he
uh,
has pictures. I'm warning you now.
well, just to just to let you know, he is going to share some photos. I told him to
Knew it.
to be generous in terms of not sharing anything too
Be
crazy.
kind, not
Yeah,
generous. Be
yeah,
kind.
be kind to us. So looking forward to it, and um, we'll probably look to have Dr. Delgado on. I think maybe another month out, we'll reapproach this
Okay.
and maybe expound on the other points to his article. But other than that, I appreciate everybody joining in. Jose, appreciate your time as always. It's always
Yeah, yeah.
fun hearing you guys go back and forth. Um, but like I said, I'll be sending out that article that Dr. Delgado provided Jose and myself. And just be on the lookout for next week's webinar registration. Look forward to seeing everybody next week.
Thanks, guys. We'll see you next week. Stay warm and out of trouble.
Stay warm, stay out of trouble. We'll see you then. Thanks, Jose.
Bye.